about the papers that I handed out to everybody or the ones that were handed out on Saturday, same thing. Now, I want to emphasize that this is not something new. This is something we've been doing all along. I just put it together in this format to encourage your thinking about systems. We're sort of moving out of structures and into systems. We've already started the systems and we're in there, and you need to think a little differently about systems. And also, all the stuff we're learning in systems, we've already covered in structures. Everybody with me? Okay, so I use this image here. This is part of the posterior column medial meniscus system. And Dr. Hawley talked about this. Everybody okay with the light? And we'll use this as our example. We use this as our example. Now, if you look at the handout, there's five questions, not questions, there are 5 statements on that page. And these all apply to everything we're looking at. And if you can basically answer those questions about the structures we're talking about, you've got the answers to all the questions. Because everything is covered in that. For example, the first point is identify the structure. Well, we've been doing that. Rest on nucleus, okay? Everybody got it? Easy. Identify the structure. Point 2, what is the blood supply to this structure at this place in the brain? Posterior spinal artery. So if you look at, for example, the medial meniscus pathway, just as an example, okay, here we have part of the medial meniscus right here and right here. What is the blood supply to that structure at that place? Anterior spinal artery. So as the system changes, the blood supply changes. Basically, the ascending things go from a vertebro-basilar pattern to a cerebrocortical pattern. So you just look at the structure, what's the blood supply, blood supply, blood supply, blood supply, blood supply, blood supply, at that level. What is the structure doing? What is this structure doing? It's conveying proprioception, discriminative touch. And that is conveying it from the lower extremity on the same side. So there you've got function, laterality, everything in point number 3. Point number 4, what is the where's the structure getting information from? Again, using this as an example, it's getting information from posterior root ganglion cells on the right side, because the pathway is uncrossed. Again, laterality gives you that point gives you that information. And did we miss something? Oh yeah, number 3. I mean, what is the structure doing? It's conveying a particular type of sensory information upstream. And you could say either, you could even think of it as upstream to what the lining nucleus, upstream to what part of the cortex, what kind of information. All covered. Okay, we talked about where is it getting information from? Posterior root ganglion cells in posterior root ganglia. On the same side, on the right side. Okay, what is that structure talking to? Or whom is it talking to? It's talking to the ventral-posterior lateral nucleus of the thalamus. On the right side. Again, laterality, modality, everything you need to know about that part of it. Does everybody see what this is? Yes, no? Anybody awake? The point is, all the systems that we're talking about, these things apply to. Spinal trigeminal nucleus, tract, cortical spinal, medial meniscus, it all applies to all those things. And that gives you all the answers, or I would say 95% of the answers that we would expect on the test are covered in these points here. But the important thing is, these points relate to every structure we're talking about, every one of them. Thalamus, cortex, BPM, BPL, whatever. Everybody follow me? And I did this to try to help everybody sort of condense things down and think, you know, this is all related. It's not a bunch of individual facts all out here that have no relationship one to the other. Everybody got it? Think you got it? Again, anybody awake? Okay? If you have questions, let me know. And if you came in and didn't get a copy of this thing, see me after lecture. Okay? Okay, now let's go to what we're talking about today, anterolateral system. And this applies to the anterolateral system, all the structures we're going to talk about today. Okay, here are objectives. Here are objectives. You've had a chance to look those over, so we're going to work on that. And I know we're kind of beating you to death with topography, but this is just a reminder. The topography of the sensory cortex that applied to posterior column medial meniscus applies here, because ALS fibers are conveying information is going to end up in the same part of the cortex, So we have a big representation for the face and hand right here, especially the thumb. So this is a big representation here, the bold, big representation. But you see the hand is a little bit smaller, but the entire upper extremity occupies less than the hand. So everything at the upper extremity is a smaller representation than the hand. The trunk, as you can see here, is really tiny, and this map was all generated on humans by a neurosurgeon and a couple of his buddies in Montreal in the 30s. That was back when they could take a tumor out, and there wasn't a thing such as getting the patient's permission to do something else while they're there. And this is not meant disrespectful to these guys, because they realized this was a unique chance to examine the organization of the cortex. So they would stimulate little areas of the cortex and record what was happening. And that's how they came up with this map. Okay, so the trunk is really tiny right here. And as we've said before, the hip, think of the hip as being the location of where the postcentral gyrus turns into the posterior paracentral. And again, it's a pretty small area right in there. The lower extremity is real small, and it's located on, so the hip is just as it turns over, and the lower extremity is down in this area here. This is this cingulate sulcus right here, the marginal branch of the cingulate sulcus over the marginal sulcus. Okay. Now, rather than have an example of a case here, it's a little later in the lecture. I will get to it in a minute. This is just sort of a review of things we've been talking about. Question: does postcentral gyrus equal somatosensory cortex? Yes or no? Does postcentral gyrus equal somatosensory cortex? Are they the same thing? Can you use them interchangeably? Anybody? Nobody wants to walk out on the limb? No. Postcentral gyrus plus posterior paracentral gyrus equals somatosensory cortex. So the first question is not interchangeable. The terms are not interchangeable. And over the years, I've heard a lot of clinicians in talks talk about the representation of the body in the precentral or postcentral gyri. So I was wondering if they were working with people who had no lower extremities. That's the only way you could get there. Everybody see it? Everybody okay? I know we're talking about terms, but I think it's important as you go through your educational process to use the language appropriately. Okay, somatosensory cortex is the same thing as areas 3, 1, 2. We'll get to the answer in a moment. Areas 3, 1, 2 are equal to the same thing as postcentral gyrus. Anybody? What about this one here? Yes, no?
Yes.
I saw some heads bouncing up and down. Yes. Somatosensory cortex is precentral gyrus and posterior paracentral, so it's the same thing. It's the representation of the body. Area 3, 1, 2 is the same thing as postcentral gyrus? No. Because postcentral, there's an area 3, 1, 2 in the posterior parasite coil. Everybody, I'm not trying to beat a dead horse here, but everybody see how the terms are either the same, can be used interchangeably, or are different and mean different things. Okay. Now, receptors conveying nociceptive input. The term nociception refers to tissue damage, and it's a very common term used in association with the ALS and its projections, nociception. And the two I have circled here are free endings that are called C fibers. These are commonly referred to as unmyelinated, and we'll talk about that in a minute. And A delta fibers, which are referred to as finely myelinated. Those are the two principal receptors that are for nociception, or what we commonly call pain and temperature. Now, the hair follicle shows up here too, because it shows up everywhere. As Dr. McCulley noted, it is a directional receptor. In other words, if you hold your arm up and run your hand up and down your arm, and just touching the hairs, your nervous system encodes what's going on, the direction of the movement. So you can tell when you go this way, you can tell when you go that way. So, but they also send information in the anterolateral system. So we include them here with a thin outline to recognize that fact. Now, these are the characteristics of the two types of fibers that contribute, the predominant contributors to the anterolateral system. And we'll talk about their morphological characteristics in just a minute. A delta fibers are mechanical nociceptions, and they do tissue damage, thermal, touch, all kinds of things. That is information related to mechanical stuff on the skin. They have a differential response. You have a low intensity stimulus, they respond a little. You have a high intensity stimulus, they respond a lot. So their response rate is related to the input, to the degree of input. They're commonly called type 3 fibers, which are 5 to 30 milliseconds per in the conduction velocity. So they're fairly slow compared to posterior columns, which are fairly fast. And they have a diameter of 1 to 5 micrometers. So they're not only slow, but they're small. These are lightly myelinated, and they have small cell bodies in the posterior ganglion, and they enter what is called the lateral division of the posterior root. The medial division is reserved for incoming fibers from the posterior column system. So, and they will go into the posterior lateral fasciculus, or sometimes called posterior lateral tract, and they will ascend or descend around 3 segments or so, and then enter lamina 1, 2, and 5 of the spinal cord, and that is their predominant targets. Now, you may have run into this term in your reading. These are sometimes called, or are frequently called, the direct pathway, or the neo-spinothalamic pathway. Neo meaning new. So this information in this regard is coming from the receptors to the spinal cord, up and directly up to the thalamus. It's not stopping along the way and getting a soda or something. It's just going straight up to the thalamus. Okay, so we have well-localized sensation. In other words, you can tell exactly where it's coming from. C fibers, and these are the ones that are unmyelinated. They respond to a lot of different nociceptive input, but of the same type. They are the same as the A fibers that having a differential response, low intensity stimulus, and the example of that would be putting a pin on the body of your foot versus stepping on a nail. Those are the same types of stimuli, but one is less intense, the other one is very intense, and gets this corresponding corresponding reaction. These are commonly called type 4 fibers. These are tiny little butters, 0.2 to 1.5 micrometers in diameter, and they are slow as everything. So they're transmitting information. It's very slow. Takes a lot of time to get there. this kind of input is poorly localized. And, which means you can't tell exactly where it's coming from. And they are involved in the pathway that gives the affective component to pain. In other words, you have some pain that you can say, oh, well, I know exactly where that is. It's on my big toe. You don't have to look. You can localize it very quickly, very precisely. Other times you have, oh, you know, I have discomfort from my lower extremity. I'm not sure where it is. I think it's below my knee somewhere. And that will change your behavior. If it persists, what's it going to do? Make you cranky, right? I think everybody has had an experience like that one time or another. My wife is going to go see the kidney guy, and she's been cranky for a couple of weeks. Okay. These are commonly called unmyelinated, but they also have small cell bodies with posterior root ganglion. Same origin for the first order neurons. These also enter the lateral division, but these will ascend maybe 1 to 2 segments before they terminate in the posterior horn, and they terminate predominantly in laminae 2 and 3. And these contribute to what we call the paleospinal thalamic pathway. It is an older pathway conveying pain and temperature types of information, and it is poorly localized, and it has this affective component, can change your behavior. And it's important, but it's a different type of importance than the neospinal thalamic, which is very quick. So those are the characteristics of the two pathways that we're talking about, and they ascend together. In other words, but we'll see they have different responsibilities. Now, what 3 morphological features are directly related to the successful transmission of an action potential? Okay, diameter of the axis cylinder, which is right here. Thickness of the myelin sheath, which is right here, and internodal distance, the distance between the nodes of Ranvier. This is a picture out of your textbook. This represents an oligodendroglia cell, which is the myelin-forming cell in the central nervous system. It is the same thing as a Schwann cell in the peripheral nervous system. As a matter of fact, you can think of it as the Schwann cell of the CNS. One difference, however, is that one oligo cell body will contribute myelin-forming extensions to wrap around a whole bunch of axons. So one oligo will myelinate a whole bunch of axons in the central nervous system. One Schwann cell in the peripheral nervous system will innervate one axon and only the internodes on that axon. So if this was a piece of peripheral nervous system here, we have a Schwann cell there, a Schwann cell there, a Schwann cell there, there, and there. So the internodal distance is one of the things that relates to the successful action of it, and that's because you'll learn in physiology that the transmission of the action potential is from this node to this node. So if there's nodes are real close together, it takes a lot of time to go boing, 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 boing. If the nodes are real far apart, it takes less time to go boing, boing, boing. And here is what we would call an lightly myelinated axon. This is the axon here. This is the nucleus of the Schwann cell here. So we have, this cell has internodal distances, just like this. Now, if we don't have myelin on the real small axons, then how do we get transmission of action potentials? You have to have that, or there is no transmission of action potentials. One of the commonest things you see in demyelinating diseases is simply a lack of action potentials. They can't go anywhere. Well, what we have is this kind of situation. This is a Schwann cell. This represents an unmyelinated axon in the periphery. This is the nucleus of the Schwann cell, and all the little axons lay in little troughs in the Schwann cell membrane. No myelin, that's correct, no myelin, but there are internodal distances between the Schwann cells holding the axon segments. Everybody follow? So unmyelinated is an acceptable way of thinking of these, but they do have a way of propagating the action potential from node to node. see electron micrograph. There's the nucleus of the Schwann cell. There's the thickness of the layer right there. And here is the axon. And here is a Schwann cell. And all these little white things surrounding it are axons in these cytoplasmic troughs. And again, this is very slowly conducting. This is more rapidly conducting. Now, nociceptive endings are the two that we talked about A delta and C fibers. They enter the posterior lateral fasciculus right here. The A delta fibers will ascend or descend slightly more than the C fibers, and both of them then will send collaterals into the posterior horn to their predominantly respective lamina that we talked about, and synapse on a tract cell right here or right here. And it crosses the midline and enters the ALS on the opposite side. Now we know from many sources that there are interneurons between the primary afferent fiber and the tract cell. Many of them, there are some that are direct, that's true, but there are also many others that have one interneuron. We don't consider the interneuron one of the neurons in the pathway. So this is the first order neuron in the posterior root ganglion. These are second order neurons there because their axons are forming the tract on the contralateral side. So those would be the second order neurons. I'm sure that earlier the guys who were doing this, a lot of this work early on, decided, there's multiple possibilities here. Some will go through two interneurons. What do we call them? So they decided to make it the tract cell, which was a good idea. Okay, we saw this image yesterday. This is the medial division of the posterior root with the heavily myelinated fibers. This is the posterior lateral fasciculus with lightly myelinated fibers. And these are the A delta fibers and C fibers. And here we see on the opposite side, here's the posterior lateral fasciculus. And we have some heavily myelinated fibers. The ones that are going inferiorly in the cord are related to reflexes. Muscle stretch reflexes. Have you ever been to a doctor and you're sitting on a table and he hits your patellar tendon with a hammer, and before you can even think about it, your leg jerks. That's the patellar tendon reflex. In the case of the fibers coming in through the lateral division and the posterior lateral fasciculus, that are these lightly myelinated fibers, they will synapse on cells. This is lamina 2 right here. Lamina 1 is the posterior marginal nucleus. It's a thin layer of almost one cell layer thick, just capping over. This is lamina 2, and then 3, and so on and so forth. These fibers will cross down through the spinal cord and cross right here at the anterior white commissure, and then proceed across the midline and stack themselves up in the anterolateral fasciculus on the contralateral side. So these fibers are crossing, contrary to what we talked about in the posterior column medial meniscus fibers, which are crossing in the medulla. These fibers are crossing within a couple of levels of their origin. And if we look at that in this drawing, we see the fibers are ascending a little bit and then crossing the midline and ascending just a little bit more and going up into the tract. So what this results in, if we have the damage right at this level to the crossing fibers, that the defect that the patient is going to experience, or the physician is going to see, is about 2 levels down, about 1 level below the actual damage, and will reflect only the fibers that are damaged in the anterior white commissure. So let's say there's 2 anterior white commissures damaged, the patient will have a little strip of anesthetic skin around the body. But below that point, it's going to be fine, because all the fibers down here crossed in the anterior commissure below that level. They got over to the other side, they got into ALS, and they're going to pound. Do I see? So that would help tremendously in localizing the level of lesion in the spinal cord. For example, I think we said before, the nipple is T4, the umbilicus is T10, and the inguinal area is T12. So if you have damage up and down on the thorax that would affect the thorax, you can localize it by bilateral deficits. Bilateral because both fibers are going from both sides are crossing. Now, if we look at the opposite, which is a hemisection of the spinal cord, which damages the entire ALS, then we have a loss of pain and thermal sensation beginning about 2 levels below and all the way down the rest of the body, because this lesion right here is damaging the entire tract. And that would begin about 2 levels down, because as the fibers cross the midline, they ascend about 2 levels. And I've seen all kinds of variations on that. We're just going to give you 2 levels, and that's fine. So this would be an example of a syringomyelia in which the central part of the cord is damaged versus a hemisection right here in which the tract itself is damaged. And of course, if you have a hemisection of the cord, you can have posterior column damage. Okay? The difference is posterior column damage, if one side of the cord is taken out, the posterior column information is coming from the opposite. It's going to be on the side of the lesion, and the pain and temperature on the contralateral side. Okay? If you have any questions, please interrupt me. I know I get short-handed. Okay, now let's look at fibers in the ALS. The first order neuron of the cell body is in the posterior ganglion right here. It comes into the lateral division of the posterior root. The heavily myelinated fibers are going into the posterior part of the root. Posterior column fibers turn rostrally, as we learned the other day, and send some collaterals for reflexes. The second order neuron, the tract cell, sends an axon down across the midline and becomes sequestered in the ALS as it is being formed and sent. So the second order neuron, the tract cell, is in the posterior horn right here. And the third order neuron, which we'll see in a few moments, is in the ventral posterior lateral nucleus of the thallus. And again, this does not take into account interneurons, which I don't know of anybody who teaches the neural course that takes into account interneurons. There's almost an infinite number of possibilities. So once we get in the cord, as the fibers are coming across the midline, they come across, for example, the low ones come across and they stack up out here, sacral, then lumbar, then thoracic, then cervical, and higher cervical. So the lower fibers are represented laterally in the tract, the upper fibers represented medially in the tract. Everybody follow? So in other words, if you had some damage coming from lateral towards medial, it would start pressing on the cord here and then here. You would have a deficit on the contralateral side of the body, beginning in sacral and coccygeal levels, and then going up. So there would be a loss of thermal sensation, for example, in the sacrum, which is on the buttock, and then it would go down quickly down to the lower extremity and start coming up the lower extremity. And that would represent damage to these ascending fibers on the contralateral side. If you had something like this going on, medial towards lateral, you would get cervical first. And then it would drop down. You would have cervical problems on the opposite side. Then it would go down into the thorax. And if it was bad enough, it would go down into the lower extremity. And those are called ascending and descending sensory losses. And they can be predicated on damage to the spinal cord. Now, here's the blood supply to the cord that we've already looked at before. This is the ALS, posterior columns here, corticospinal here, and you can see the basal corona serves the surface of the cord. Posterior spinal serves almost all of the posterior column nuclei, and the anterior spinal serves most of the gray matter and medial parts of the ALS, the lateral parts being served by the basal corona. Okay, now this is a summary of some of the tracts in the anterolateral system. We're not going to name them all. We're not going to ask you all of them on a test. So take a deep breath. Have a to read. Some of them aren't important. Of course, one of the most important ones are the spinothalamic fibers. There's an interesting history concerning this tract in the primate spinal cord, which we don't have time for. And these are coming in at all the different levels and going spinothalamic and up to the thalamus, and we'll see that on the next slide. Now, spinal-reticular fibers, what does their name tell you? Spinal cord to reticular formation. Okay? Spinal cord to reticular formation. Who cares? Well, let me tell you something about spinal reticular. Reticular fiber, and this represents reticulothalamic fibers. The A delta fibers are the ones that are going straight up. They are the neospinothalamic. The paleospinothalamic fibers are those which come up and branch into the reticular formation of the medulla and pons. And one of the things they terminate on, and I think Dr. McCullough mentioned this, they terminate on neurons in the reticular formation that are inhibitory and descend back down the spinal cord. What use would that serve? Well, there have been a number of examples of this. You're driving down the interstate and you see a car run off the road, flip over or something, and start burning. Well, there have been people that have done this. It's been reported. They jump out of their cars, they run over, and they grab the door handle, and they pull it open, and they reach in and unhook the seat belt and drag the person out. Have you ever heard that in the newspaper? I mean, it's been in the newspaper. I remember one time there was a story about a truck driver who had a crash, and the guy went and did that for the truck driver. And you get done, and guess what? Wow, I got really bad burns to my hand. But you didn't sense that pain when you were doing the act. Your emotional part of your brain, your adrenaline system and everything, overpowered and shut down the pain fibers so you could do this emergency act. Okay? So what we have here are reticulospinal fibers. They come from both sides and descend and inhibit, presynaptically inhibit the pain fibers. Which means during the emergency situation, the pain fibers are still going up, they're still doing their job. They go into the reticular formation, some of them, and when the input to those fibers is high, they're firing back down the spinal cord and inhibiting the pain fibers coming in on the posterior root. When the emergency is done, oh my gosh, I got burns on my hand. You know? In other words, people can do this and never notice they did it. There was an article in the paper many years ago about a woman who had like a little car of some kind, sports car, a small car, and somebody was working on it for her, and it fell off the jack onto them, and they were yelling and screaming, and she actually went out and lifted it up so the guy could curl out, and in the process crushed two of her vertebrae, which she didn't know about until she got the car back down and then had this real intense pain. So this is an active system that you all use every day to inhibit pain. For example, if you're running up and down the steps and you twist your ankle, you're not going to fall down because it's something going to inhibit that pain enough to give you a chance to get a whole right. So spinal reticulars are important. Now, spinal mesencephalic, these are all put together because they are fibers that are going through the mesencephalon. And so we're not going to mention those a whole lot, and we're not going to mention these. But these two are really important because they're involved in systems that you have experience with on a daily basis. And again, the pain fibers come in, go up, send collaterals to the reticular formation. They synapse in the reticular formation on what are called Raphe nuclei, R-A-P-H-E, Raphe nuclei. What's a Raphe? It's a seam. Okay, so the seam of the medulla and pons is the midline. So the Raphe nuclei are located right along that seam on both sides. And the thing is, the right spinal fibers send their information downstream bilaterally, because the action you're doing is bilateral. Okay, an overview of the system, we just looked at some of this right here. The posterior ganglion is the location of the first order neuron. There's a peripheral process which goes to the receptor, and a central process which enters the spinal cord. Posterior horn is the location of the second order neuron, and these cross in the anterior white connoisseur. The anterolateral system spans the entire brainstem. We can see it here, here, and here, and is located in almost the exact same position. The lateral part of the medulla, the lateral part of the pontine tegmentum, and the lateral part of the midbrain. And within that pathway, it is somatotopically represented. Don't try to remember what it is, but the lower extremity is always lateral, and the upper extremity is always medial. And we're not going to ask you a question on somatotopy in the tract, okay? Because that would be a nasty question, right? Everybody agree? Okay, everybody agree. The thalamus is the location of the third order neuron, which is in the ventral posterior lateral nucleus of the thalamus. And again, there's a representation of the entire body without the face, because the face comes in on the trigeminal system. And of course, it all gets to the sensory cortex. And it gets to its respective part of the sensory cortex. Okay, and we put this one in to remind ourselves that we have an ALS right out here. And we also have information coming in from the pons down to the spinal trigeminal tract and on down to the lower levels of the cord. And that tract is located right here. The spinal trigeminal nucleus is right here. And the important features of this is that the corticospinal ALS and posterior column are all located within this area. They maintain the relative position in each other as we go up. And also here we have the dorsal-motor nucleus of the vagus, we have the hypoglossal nucleus, and the ambiguous nucleus, which are cranial nerves that innervate motor structures. The solitary tracting nucleus is a homologue of the spinal trigeminal tracting nucleus, and it receives visceral information from cranial nerves. And the ones it receives primarily from is 7, 9, and 10. Okay, and there's the ALS right there, and we're going to see that it goes up. But we put it this way to remind you that the trigeminal nerve is in the pons. So information to the spinal trigeminal tract that goes down through the caudal pons and all the way through the medulla comes from cells, from one set of neurons located in the trigeminal ganglia. Okay, any questions? Now, the other thing I want to mention here is vascular territories. This is really a review because we talked about it before. Anterior spinal is here, vertebral here, and the posterior inferior cerebellar artery is here. And the vascular territory contains motor structures and sensory structures. And the two that are really important is the anterolateral system and the spinal trigeminal tract and nucleus right here. And the nucleus ambiguous is also in that vascular territory. Now, this illustrates at medulla, pons, and midbrain levels the location of the posterior column medial meniscus in relation to the anterolateral system. In the caudal part of the brainstem, the ALS is about right here. It doesn't have a nice little round thing around it or something. We just know it's in that area. And as it goes into the pons, it's in the lateral part of the pontine tegmentum. But the medial meniscus, which is located here, shifts so that the lower extremity moves out, moves from this orientation into this orientation. So about mid-pons, the ALS and the posterior column system becomes closer together. Okay, why is that important? Well, here, you cannot have any vascular damage that would affect both systems, because it would be one half of the medulla would be infarcted, and that would be, you wouldn't be testing the patient for you know, touch your nose, and then you feel this on the end of your finger, because it probably wouldn't be conscious. And then if you had something growing in the medulla, that damaged one half of it, the first thing you would see is indicators of increased intracranial pressure, because that would be a massive thing going on in a really small space. Okay, we get to the pons. So now the medial meniscus is laying out, and the lower extremity part is in this area here, upper extremity here, and now this is the ALS. So now we have a lower extremity part getting really close to the ALS. And of course now this is the paramedian part of the vascular system, and these are out in the short and long circumferential branches of the basic. Because we have moved from one level of the brainstem to another level. We get in the most rostral part of the brainstem, and now we see the ALS right here, the lower extremity right here, and upper extremity right here. So now these two systems are really close together, and they're many times in a single vascular territory. That is related to the vascular pattern of the medulla. Excuse me, the midbrain. Okay, if we look at the more rostral part of the ALS, we see these branches of paleo-spinal flamming coming into the reticular formation right here. Right here, we see them synapsing on these fibers that are descending as part of the reticular spinal, raphe spinal tract. And these are the inhibitory neurons, or these are the neurons that are inhibiting the transmission of pain in the posterior column. Interestingly enough, they are also inhibiting pain transmission through the trigeminal system, because trigeminal is doing pain in thermal sense. So if you have something going wrong with your tooth or something like that, and you get under stress about it, these fibers would tend to inhibit that transmission in the spinal trigeminal nucleus from going to the thalamus. So if the thalamus doesn't get the message, it doesn't exist until the stress goes away, and then your tooth hurts again. Okay, so you can see here it is in the pontine tegmentum, posterior column medial meniscus, posterior column medial meniscus. This shifted out to horizontal because of the advent of the basilar pons and all the structures in the basilar pons. This one shifts even more out, sort of out and up, because of the advent of the decussation of the superior cerebral epithelium and the red nucleus. If they're going to be in that location, you can't have these tracks in that location. As you notice, many of the tracks in the brainstem are pretty organized. You know, you see they're pretty evident even in the stained sections. And of course, these pathways retain their somatotopy. So when the medial meniscus is here, that's upper extremity, lower extremity. When it tilts up because of the incoming red nucleus and decussation of the superior cerebral epithelium, the lower extremity is up here, and the lower extremity is up here, upper extremity is down here. So it pulls the somatotopy back within the pathway along, and we need to understand that now in both of these systems, but not in the ALS in the brainstem. Now we get up into the thalamus right here, axial view here, a different axial view here, an MRI right here, and we have this large nucleus here is the VPL, this one is the VPM, and you'll notice that the VPM is kind of tucked under the central-median nucleus. So that's why we qualify its position here. But sometimes if the axial section is very low, we can pick up most of the VPL and VPM right here. And this is part of the central-median right there. So the relationship is together. Now, we know this is pulvinar, right? Everybody okay with that? Pulvinar? This is something else, but that's okay. It's part of the genicular bodies, because the genicular bodies are kind of tucked underneath the pulvinar on the caudal surface of the brainstem. And so so we have here these two nucleus, BPL, sort of representing body without the head, BPF, the face and oral cavity. And of course, the blood supply to this area is largely by way of thalamo-geniculum. And the name tells you what's being served, thalamus and geniculate nuclei. And of course, knowing the relationship of those to the tracts, okay, it's got to be these nuclei also, because it's called the thalamus. Okay, now. Okay, let's look at trigeminal pathways for a minute. And again, Dr. McCulley mentioned a lot of things about this, so I'll kind of put this as a summary. The incoming sensory fibers originate from neurons located in the trigeminal ganglion, the ganglion of the 7th nerve, the 9th nerve, and the 10th nerve. Because remember, those 4 cranial nerves, or those 3 cranial nerves plus 5, give rise to fibers conveying either stuff to the related to the oral cavity, which is going to be taste and visceral, some general visceral sensation, or the surface of the face. For example, the dermatome for this division of the 5th nerve right here comes up and ends at the ear. The surface of the front and back surface of the ear has general somatic information coming on the 7th nerve. The external auditory canal, which is the 9th nerve, gets some too, and the innermost parts of the tympanic membrane get it from the 10th nerve. So you have information coming in on those nerves that are not only related to taste, but are related to general sensation. And of course, these would go to that part of the sensory cortex. Okay, so we have first order cells in the ganglion of 5, 7, 9, and 10th nerves, and those are all number 1. The second order neurons in the spinal trigeminal pathway and principal sensory nuclei are number 2. So here is the principal sensory nucleus is right here, and this is the spinal trigeminal nucleus right here. That is the locations of the second order neurons in the pathway. So the information is coming in on this side, down the tract right here, terminating in the nucleus, and then these nucleus will have second order neurons that cross the midline diffusely. There's not a nice little trigeminal decussation, but they cross kind of diffusely. And they collect in the ventral trigeminal thalamic tract over here, and which is sort of loosely organized in the brainstem and generally associated in the area of the medial lemniscus. They go to the BPL, which is a position of third order cells, which are the ventral posterior medial nucleus of the thalamus at number 3 right there. The principal sensory nucleus gives rise to cross fibers, which join the ventral trigeminal thalamic tract, and gives rise to some uncrossed fibers that are going up into the BPM on the ipsilateral side and conveying some information from the oral cavity to that. All right. Okay, these are the things that were in your stuff to look at and think about. So we have 3 patients present with symptoms requiring MRI or CT. These images are few above. Now, what I want to tell you about these are 3 actual cases, and the deficit that these patients had were actually that. I'm not making it up. I'm honest with you. I know sometimes you probably think, oh, geez, Dr. Haynes makes this stuff up. It never happens. And for example, we had a situation one time where there was a 21-year-old woman and an 11-year-old girl that had vomiting. The only thing she had was wrong was they just constantly vomited. And it was a lesion so small in the medulla that you almost couldn't see it. And when they do an MRI, they take a slice and then move ahead a certain distance and move ahead. The lesion was so small, it showed up in one slice, and it could have been missed if the slice was slightly off. So it can be extremely small lesions and have a very specific deficit and very obvious deficit. Oh, okay. So, what symptoms would be most apparent to these patients? What specific structures and or pathways may be involved in these patients that would correlate with a particular symptom? Okay, first of all, where's the lesions? Say again? Midbrain, absolutely. Midbrain here, and midbrain here. Which is the largest one? Say again? Yeah, B is pretty large. This one's slightly smaller, and that is minuscule. So what do you think the deficits are? What are the deficits in this one here? Don't say auditory. Students always ask, well, what about the breaking of the inferior colliculus? It's out there. Yeah, but it's not part of it. So what would you have here? Here you have normal tissue right along the edge there, which is different than that. Here you have a smaller lesion, you have a bigger lesion, but it's moved in a little. It's more internal into the brain. And here you have a lesion that shares a feature with that as being out on the surface, but it does not extend in very far. Everybody see it? Okay. Let's look down here real quick. Okay. You recognize the pathways? ALS, posterior column, and medial lemniscus pathways. Okay, so this one here that's where that lesion is, right on the surface, and it got only anterolateral system fibers. So it was the loss of pain and temperature on the right or left side of the body. Right or left?
Left side.
Left side, correctly, because these fibers were already crossed down the spinal cord. And this is the right side. This is the right side right there. Absolutely correct. Okay, here you got a bigger lesion, a little internal, so you spare this. Now what you have is here. So what deficits are those? I'm stealing from Dr. McCollum now, but I think I'll be okay. What deficits? Proprioception of upper and lower extremities. What side? On the left, because it's the right side of the lesion and we're above the next station. Here we have a situation where ALS is involved, right down in this area here, and just the lateral part of medial lemniscus. So what would you have in this one here in A? Okay, you have a left-sided pain and temperature deficit on the entire body, and a left-sided deficit in the posterior column system on the left side, but only in what part of the body? Lower extremity, right. Great, great. Okay, any questions? Please kind of go over these and look and help yourself review. You thank the copyright.